So welcome everyone. My name is Joanie Bouchard. I am the Interim Chief Regulatory Officer for the college. We are very pleased to host this webinar today with all of you. I want to start by thanking everyone for taking time on a Friday during lunchtime to be joining us for this webinar. This is the fourth webinar of this series that we've done, specifically on the topic of standard and regulation changes. This is a follow-up to our HPOA webinar series that we have done between December and March in preparation to the transition to the new act. And we had identified that there was a need for more engagement and more information sharing on the topic of standard and regulation. We are happy to be able to do this with all of you today. So today we are hosting the webinar specifically for audiology, hearing instrument dispensing, and speech language pathology. With that said, the webinar is open to all of the licensees we regulate, and that was the same for the other three that we hosted. The grouping was determined based on the degree of changes that we had with the former set of standard that you guys had. So in the future, if we were to do further licensee webinar, the grouping might be different. We might do it for all licensee if it's a topic that is the same, but we know that based on the former set of standard that you had, there were specific needs that were different among licensee group, and that is why we did it this way. Next slide, please. I do want to acknowledge that the offices of the College of Health and Care Professional are located on the ancestral and unceded territory of the Coast Salish people. For our Vancouver offices, that is specifically on the Musqueam, Squamish, and Tsleil-Waututh Nation. And for our Victoria office, it is on the Lekwungen people, represented by the Sanghi, Esquimalt, Saanich, Pocatchin, Tsleil-Waututh, and Sartlip and Sekom Nation. We're really grateful of the privilege that we have to be working and living on these lands, and we do recognize the special relationship with the lands and water that the first people of these lands have had and continue to have today. Next slide, please. I've spoken briefly in my introduction that we are doing this as a follow-up to our HPOA webinar series. These webinars are still available on our website and are really good source of information for you. We saw that in the pre-submitted question, there were a lot of questions that we were able to answer and address in these webinars. So we would definitely encourage you to consult and look at these resources. They are available on our website under the tab of legislation and bylaw. If you go into the HPOA section, you will find a specific tab that are related to our webinar. Next slide, please. So today with me, I have the 3 practice advisors from the college and a couple of additional staff that will be here to help answer a question that you can enter in the chat at any time. Not the chat, the specific page for Q&A. The chat is not enabled for this webinar. So for audiology, we have Nick Gronman. For hearing instrument dispensing, we have Sabrina Sunner. And for speech language pathology, we have AJ Hildebrand. And at the end, for the question, there will be myself and Susan Paul, who's the regulatory transformation advisor for quality practice, that will be available to answer a question. Susan was the lead for the harmonization of our ethics and practice standards. She knows them ins and out. She also knows your legacy standard that were retired as of April 1st ins and out, and will be able to contribute to answer to questions. So each of the practice advisor will present on the common themes of questions that we have heard from you. since April 1st. And then at the end, we will answer the question that we received that were pre-submitted, and we will take questions that we will have received during the webinar. Just to note that if you have submitted questions that are either related to licensure or quality assurance, we will not prioritize them today. We really want to have the focus on the webinar today to be on standards and the regulation. With that said, we will plan more engagement probably after the summer to address, for example, the topic of quality assurance, where we know people have lots of questions. And so please know that if we don't address your question today, it's because it's not directly related to the webinar today, or potentially they've been already addressed in our HPOA webinar. So please stay tuned to get more information on this. Okay, quick. I think I should be quick to end it off to Nick. So while we're offering these sessions, we've heard that it would be really useful to provide additional information to support you in this transition. There's been lots of changes since amalgamation, transitioning to a new regulatory framework with a new act, with harmonized standard is another big change. And so we're hoping that the webinar will help you in understanding how to apply these expectations in your daily practice. And next slide. In terms of what to expect, I think I've already covered it. And so we will have lots of time at the end for questions and are hoping that we will be able to clarify a little bit these areas that are still unclear to you since the transition to the new legislation. I think lastly, the last slide, this is just to point out that today we will be covering information that are related to our standard of practice and two key regulations. And so if you are not aware, these are you can easily find them by Googling them. And so wanted to point out these reference documents. So I will pass it on to Nick to start with audiology.
Perfect. Good afternoon, everyone. Like Joni mentioned, I'm Nick Redman. I'm the practice advisor for audiology. So just next slide here. So yeah, I just want to focus on kind of two main themes for common questions I've been getting. The first has to do with delegation. And so just essentially we're moving away from the really prescriptive language that was in the old communication health assistance delegation and assignment clinical practice standard. In essence, things haven't changed too much, but now it's best to refer to the bylaws, specifically Section 10, which speaks to delegation, and the new supervision practice standard. So like I said, it's less prescriptive. It's much more higher level language with respect to the approach to delegation, but really no kind of major changes there. And the second thing is just a quick note on use of title, which I'll get to in a second here. So next slide. So the new bylaws have triggered questions mostly with respect to the provincial early hearing program, the BCEHP. As we'll see in a second, the language kind of suggested that the delegating audiologist would have to have firsthand knowledge of the patient being screened. And of course, in the context of the BCEHP, this would not be possible given that babies are being born across the province in communities where there may or may not be audiologists there. And I'll kind of walk through the various aspects of the bylaws in a second here, but the takeaway message is that the BCEHP program is still going to operate as it did before. The screeners are still able to work as they did, even if the audiologist does not have firsthand knowledge of the patient. Go next slide here. So what I pulled on this is just section 10.10. And this is the conditions for delegation to anyone other than a student. And what I wanted to highlight was that bolded point in B. So this is the language that was suggesting that the audiologist would have to have firsthand knowledge of the patient. And if we go to the next slide, this will highlight sort of the exemption and the piece that I think maybe people were getting tripped up on. So in 10.11, you can see that audiologists are permitted to delegate screening tests, and of course, this would capture the BCHP hearing screenings that are done on newborns. And then if we continue to read to section 10.12, this basically highlights that the need for the audiologist to have firsthand knowledge of the patient does not apply to those screening activities, and thus making it permitted to basically continue as it did before. The only thing I'd like to highlight here is that, of course, the same safeguards and precautions would need to be in place. And on the next slide, those are highlighted here. So we can jump there now. Perfect. And so these are just general requirements for delegation. This is not specific to delegation for screening activities. This is sort of a more higher level approach to all aspects of delegation, but I just wanted to highlight that those same safeguards are in place. So um, the audiologist needs to provide appropriate instructions. They need to ensure that consent is obtained, the proper documentation is done, liability insurance, all of that kind of stuff is still there. And so I just wanted to highlight that to ensure that people are aware that things haven't changed too much. And if we jump to the next slide here, this is just very quickly some other references and resources that people may find helpful. It's another area of questions that I've been getting on the practice support side. So the first thing I wanted to highlight was the HPOA webinar that was done on January 14th. This was specific to delegation. It's not only in the context of audiology, it's across all professions, but there's lots of good information and lots of good answers there for common questions that we've been getting. And so this is found on the website. There's a recording of that webinar. The second, of course, is the bylaws. So section 10, which begins on page 76. I've highlighted a couple sections earlier here in the slides, but of course, it'd be good to read through that section in full if people have more questions. And then, as always, ethics and practice standards to consider. So code of ethics, consent, professional performance and responsibility, record supervision, these can all relate to delegation. And of course, important to review these as needed. Go to the next slide. And then this is just a very quick note on use of title. I think that this is a question that we've been getting for a number of different professions, but it also applies to audiology. So the term registered audiology or RAUD is no longer a protected title under the HPOA. That being said, the term audiologist is. And so just wanted to highlight that the use of registered or licensed, so RAUD or LAUD is not required. It's not inherently wrong anymore, but it's just not protected like it was under the old legislation. And so using the term audiologist is perfectly fine. So that's it for me. I'll pass it over to AJ for the SLP side of things. Or sorry, to Sabrina for the hip side of things.
Thanks, Nick. Um, Again, I'm Sabrina Senner. I'm the practice advisor for hearing instrument dispensing. If we could go to the next slide, please. So I just wanted to touch on one of the biggest changes for us, for our profession, which is, historically, hearing instrument practitioners could prescribe, fit, and dispense hearing instruments to patients who were 16 years of age and older if services were being provided to patients between the ages of 12 to 16, advanced certification was required. Under the current regulation, that threshold is changing from, or has changed from 16 years of age to 19 years of age. So the key takeaway is that prescribing, fitting, and dispensing would need to be with patients who are ages 19 and older. If I could get the next slide, please. One inquiry that we often get is around, more further clarity around the restrictions for general hearing services for the ages under 19. The age restriction doesn't prevent us from assessing hearing in younger patients. It is really focused on the dispensing part. So, HIDS may continue to assess hearing in patients of all ages, including performing hearing assessments, tympanometry, ear mold impressions, and we're authorized through certified practice, even sermon management. The restriction specifically relates to hearing instrument services. So again, highlighting the prescribing, fitting, and dispensing of hearing aids. However, as with all practices, all activities, licensees must really ensure they're practicing within their competence and have the knowledge, skills, judgment necessary to provide safe care in any situation. And if a patient's needs exceed the practitioner's competence or experience, further consultation, collaboration, and further referrals should always be considered. If I can get the next slide, please. So another key change to add to Nick's talk a little bit about delegation is, previously as hearing instrument practitioners, we were not permitted to delegate ear mold impressions. This is an activity that could only be delegated by audiologists. Under current regulation, that has changed. So hearing instrument practitioners may now delegate ear mold impressions as well as shell modifications. Next slide, please. With that said, it's still important to understand that, allowing delegation does not mean a licensee can, simply assign that task to anyone. Our standards and bylaws outline the specific requirements that Nick did touch on a little bit. And of course, that the webinar as well touches on it, on what we can delegate and what's the process around that. So again, just ensuring that delegation is appropriate, that the delegatee has the necessary training and competence, and provide any required, the licensee will provide any required oversight or support. And of course, with any delegated activity, if circumstances are complex or the patient presents additional risk factors, the licensee should carefully consider whether delegation is appropriate, as well as always ensuring that informed consent is obtained by the patient. So, they're consenting to who is performing these delegated activities. Next slide, please. Another question we have been getting is around marketing. So, previously there were profession-specific marketing standards that contained detailed requirements regarding advertising, websites, promotional claims, where now the marketing requirements are now incorporated into the ethics and practice standards and are, they apply consistently across all professions. However, the core expectations still do, remain the same. The licensees are responsible for ensuring that any public communication is accurate, truthful, evidence-informed, and, not misleading. If I can get the next slide, please. So when we talk about marketing and public communications, we're referring to, more than necessarily traditional advertising. So these requirements apply broadly to communication with the public, including websites, social media posts, blogs, videos, etc. It's important to remember that licensees remain responsible for marketing conduct on their behalf. So, any third-party marketing company does not remove a licensee's professional responsibility for the content that's being shared. And, being aware of or taking care of when marketing claims are related to cognition, dementia, brain health, etc. So any such claims should be evidence informed and should not overstate what the available evidence supports. Information really should just focus on supporting the public and making informed decisions about their care. That was it for me for kind of the hot topics with hearing instrument dispensing. So I will pass it on to AJ.
Hi. Thanks for everyone's time coming today. I know that this is a lunchtime, and being in clinical practice ourselves too, we know how much there's that value with that, enshrining that time. So thanks for choosing to be here today. If I can get the next slide. So again, my name is AJ Hildebrand. I'm the practice advisor here for SLP. And much like my colleagues here have said, we wanted to offer some insights and answers, hopefully to help people navigate to the questions that we're getting a lot. Some key themes that we got. If there was one question that or topic that came up was changes, changes, changes. We heard resoundingly from SLPs, more than 75% of you guys included the word change or update, wanting to know from this webinar. So I'm hoping that we're able to cover that here in what we do. Primary changes, I'm going to kind of divide into four major groups. We've got terminology and scope mechanics. We've got clinical records and documentation management. We've got anti-discrimination and cultural safety obligations. We've got enhanced collegial accountability and duty report changes. Now, these are based especially on what both SLPs messaged in about as being areas that they're feeling unclear, uncertain, not confident in with changes. But I want to be clear too about something, and that to kind of bookend and frame what we're going to talk about here. While we're going to cover ostensibly changes, the theme here, as my colleagues have pointed out too, is that business is still as usual, largely. While there is totally new legislation here, and it has expanded and clarified many aspects for our 9 professions that are regulated under the CHCPBC, this should not really affect day-to-day practice. And I know a lot of people have expressed anxiety about that. So I want people to really try to really internalize that. And hopefully this will help with that. Next slide, please. So one thing that I do want to be clear about here too, as I think has been touched on here, and I've seen with other practice advisors in their webinars, is what we're going to talk about here, while it's going to apply to SLP, honestly, because of the main thrust of harmonization, reasonably probably will apply to most professions here. This will probably apply to audiology as well as hearing instrument practitioners, to physiotherapists, opticians, because we have those harmonized standards and bylaws now. And we are all regulated under the same legislation. For us as SLPs, just like our colleagues here, that means that we've moved, as Nick pointed out, from the term registrant to licensee. We are legally designated as that under the new act, and this is what we call an exclusive title. But because SLP itself is also an exclusive title, it's not necessary to say you're a licensed SLP or an SLP, comma licensed. It is inherent to that. You are still welcome to, and I know that a lot of SLPs will want to. I myself do in my email signature too, so feel free to do that. Next slide, please. So the scope of practice, as I've hinted at, it's revisions, not really changes. 2 key ones there that more acute eyes may have noticed in the past under the now retired or now rescinded Health Professions Act regarding feeding and swallowing. It used to be that the services and assessment, treatment, rehabilitation, or preventing of feeding and swallowing disorders were considered, in the context of vocal tract dysfunction, or, framed as being in the course of promoting and maintaining communicative health. That thankfully has been separated. Now we have kind of 3 tiers, one ostensibly about speech and language, one about voice, largely, and one about feeding and swallowing. They are held within Section 60 of our regulation here, the Health and Care Profession Regulation, as being distinct and sisters of each other in that. So thank goodness for that. There is an updated and explicitly codified section in there as well, Section 62.01 within that regulation that specifically states a speech language pathologist may administer oxygen by inhalation. I will admit no one clinician, certainly not one practice advisor, can be everything. And so while we are here to help and navigate, and we will get you the answers you need if you reach out to us, hospital and acute practice is not my area as much. So this has not applied to my practice as much. But what I understand of it, certainly, especially from people asking in, is how this may have changed. And again, I want this to be kind of the overarching theme. This should not change in practice. And this is at a legislative ministerial order level. So this is something that continues to evolve. And as we have more information, we're going to hopefully be able to share that with people too. Next slide, please. Nick as well covered this pretty well, so I won't belabor it, but I know that this is a very, can I say spicy point? I know that this is an area that has a lot of SLPs, I think, questioning. We had legacy definitions for delegations and assignments. While, like I say, in practice, that has not changed. Certainly the codified language around those has. So what we used to consider delegations more reasonably are typically assignments now. An assignment is going to refer to when we allocate routine aspects of care, things that are conscionable with appropriate training, background, knowledge, experience, etc., to someone else who may or may not be a licensed care professional. If they're an unlicensed care professional, especially, this usually entails a supervisory role. So it is incumbent on us where we do that. If, because the whole point of our license and why we're regulated is that we inherently carry a significant measure of the public trust. Whenever our authority is ostensibly behind that, real or perceived, it's incumbent on us to also make sure that we are being transparent about that, that we're being accountable about that, right? So when it comes to an assignment, that is something that typically, as I say, will be under a supervisory relationship. And as for delegations, interestingly, we really only at this time have one type of delegation. It's a formal legislative authorization mechanism, as I say in the slide here, where we can take a restricted activity or an aspect of practice that's not routinely part of that delegatee's permissible scope, and then give them, move over that authority. And we only really have one place. I'll come to that in a second. But otherwise, in general, I think it's really helpful for SLPs to start to try to think of things in terms of assignments. Next slide, please. So this is that one exception. Underneath our bylaws, under section 10-20 or 20, the only restricted activities, while there are many under the regulated health professions regulation, RHPR, there are a number of restricted activities named, but the only one that can be delegated is conducting a screening test that involves the insertion of an instrument, hand, finger device, or substance that's under pressure into an ear canal. Okay, so that is it. Everything else that would reasonably be historically delegated to what we would call a communication health assistant, or in this case, more broadly, an unregulated care professional, is going to be considered an assignment. Okay. And a restricted activity, as we see here, is something that's performed in the course of providing healthcare services, but is specifically prescribed by the minister as a restricted activity. So it's things like diagnosis, for example. You can't delegate that out. That might be things like putting an instrument past or a finger or what have you, past level of the pharynx. If you have a certified practice for that, cannot be delegated, right? Next slide, please. I've given a table here. There will be a few slides that I'm going to breeze through in the interest of time. I do know my SLP colleagues really like to have that information to reflect back on, and I don't think the slides are going out. However, this webinar is being recorded, so I wanted to make sure that they were still at least shared here, that information, that people can go back when it is accessible asynchronously and go back and check that information. But to make it crystal clear, I really wanted to put down a definition, clinical example, and the requirements behind that between delegation and assignment. One thing I will point out too is it can be really hard to wrap your head around this. Myself, again, we are all practicing clinicians here. I mostly work in schools, although I do some private practice as well, and I do work in the healthcare units in the summer times. I will say, out of full humility and transparency, when I was coming up with the delegation clinical example at first, it was a bit of a journey for myself, and I'm steeped in this. Like we are in regulation here. I actually came up with an example that a colleague had to show me. That's not actually correct. This is really the only delegative activity that can go under here. Okay, so really, again, more often than not, my asterisks at the bottom. Assignments may feel like delegations by virtue of occurring under SLP supervision, but they are distinct under the new legislative terminology. Next slide, please. I don't want to belabor this point, but we do get a lot of questions as well about how delegations formally and assignments also relate in the context of consultation. And this is not a regulatory term. It's not a standardized term. I want to be clear. But for lack of better term, what I would maybe refer to as unlinked work. This is work that might be concurrent services, but is work in which you're completely detached as the clinician, as the SLP providing care. It is not something you are involved with at all. Often there are questions about, well, what's my role in that? What's my responsibility? And the fact of the matter is, your main roles and responsibility with any unlinked work is to make sure that you are communicating and being transparent about that boundary, that you are not connected with that. Because again, at the end of the day, whether you are providing service and you need to be transparent about what your role is and what you're providing, or whether you aren't, and you need to be clear about that. The point is you're being clear because you carry that measure of public trust behind you. In all things, consider that. In all things, couch that in the code of ethics, right? Next slide, please. And so again, I'm not going to belabor this slide, but I would encourage people who do have questions about that to come back, look at this index, because I've tried to give some examples here as well to really clarify between those two. Consultation, there are requirements that still come with that underneath not just the Health Professions and Occupations Act, but in our case, more explicitly within our standards, right? Even sometimes I think applicably in the bylaws as well. I'd have to go and look to confirm. But just because you're doing consultation, it does not mean you don't have requirements ethically there as well and regulatorily. Next slide, please. So regarding clinical records and documentation, this is a very, very hot button question. The main thing that has changed is obviously our previous documentation records management standards and practice guidelines are retired, and we have harmonized all of our standards now as of April 1st. That's been covered enough, so I think we'll go on to the next slide, please. But what I really, again, and I've hinted at this a little bit along the way, I really want people to internalize a lot of these standards, as Nick and Sabrina have pointed out, are very top level. That is intentional. The goal here is to find the right touch regulative balance here. We are not looking to overregulate and micromanage what licensees do. The whole point of having a licensee and having access to that public trust, by virtue of when you walk in the door and you say you're an SLP and suddenly you have trust that you may not have earned, but collectively the profession has earned. That is what we are protecting by also protecting the public. It is something that we take very seriously in regulation, and we know as clinicians that you guys take very seriously too. Our role is to uplift and support the public, even if the way and the mechanisms we go about it are different. For a licensee's perspective here, that really means really considering and couching everything you do in those guiding principles. Even the standards themselves are themselves derived from our registrant or our licensee code of ethics, pardon me. See, old habits they take time. So in all things, I really encourage people to go back to the code of ethics. It's 2 pages. It's like, I think 12 principles. And from all things derive that. If you are meeting all of those principles, especially where 2 things are inherently in conflict and you don't know how to proceed, typically, if you can show defensibility where there's no prescribed answer requirement and you can couch it in that, if someone were to question you and you were to be able to say that reasoning, you've probably met the standard typically, right? But you can always reach out to us in practice support. We will make sure you guys get that contact information because we absolutely love helping people walk along there so you can feel confident about your competence with that too. Next slide, please. This is a slide I wanted to make because this comes up a lot too. I think a lot of people this is very broad as well, but just briefly, people often ask questions where they want to know about a policy that maybe is a workplace or employer requirement. Okay, so the workplace has a certain requirement, as long as it's not straight up countermanding or not complying directly, especially ethically, with appropriate legislation or regulation. Wherever it's reasonably lawful, that is actually part of the regulatory process. So from most enforceable and least specific, we started legislation and it goes down that umbrella largely, that upside down triangle there. It gets more and more narrow, more and more prescriptive, but often less and less enforceable. But all of these steps in the ladder here are absolutely part of the process. So as you know, the bylaws are going to be more specific than legislation for our college, and that is intentional. They actually narrow the scope of practice further from what legislation says. Our old legislation would have said the scope of practice for a speech language pathologist is speech language pathology. No doubt. But the point is, that is because that is the apex of enforceability, right? And from everything else derives that. Just like I said, from our code of ethics derives our standards. Similarly, it's important to understand that, the standards come from our bylaws, and workplace requirements are legally enforceable and things that we are required under licensure to follow where they are conscionable and ethical, and follow any applicable laws or local laws or legislation, right? But at the end of the day, the very bottom there is you and me. As licensees, we actually have a duty and an obligation to both do the services that are in our scope, to recognize what our scope and competence are, and to also not engage in that where we recognize ourselves to be discompetent, where, for example, because I do not work with swallowing, totally within my scope, but dysphagia management, I would be discompetent at this point to actually in practice do. I would have to take it upon myself to actually retrain and think about and read up and practice and come up with a plan how to safely build my skill again. So at the end of the day, this is why if you call practice support 2, my 5-second pitch is we'll never tell you what to do, but we also can't tell you what to do. Ultimately, it is up to individual licensees like you and me to determine whether we are competent and appropriately skilled and within scope for any practice we do. Next slide, please. Okay, I'm going to be quick about this. Last kind of things to be aware of here. This is a big change, largely with the new Health Professions and Occupations Act. A lot of the expansion has to do with anti-discrimination and in particular Indigenous specific anti-racism. One of the big pieces of this is no longer a college policy or an ethical guideline. It's actually a statutory legal requirement. So we're actually compelled to take active anti-discrimination measures that foster physically, culturally, socially, emotionally, and spiritually safe practices. Next slide, please. In addition to that, as I say, it also the act explicitly details Indigenous specific anti-racism requirements. So that, it's incumbent on us as licensees to consider anti-racism tools, how we support reconciliation with Indigenous peoples in alignment with UNDRIP, as well as Plain Sight Report and DRIPA at a provincial level for associated legislation. Next slide, please. With regards to duty report, we've always had duties to report that obligation. It's continued under the HPOA, but we also have a statutory duty to report another licensee if we have reasonable grounds to believe that their continued practice represents, and this is a really important piece, a significant risk of harm to the public in their continued practice. Okay, our conditions have expanded under which a duty report may be triggered, and previous reporting requirements were generally limited to public danger, hospitalization, or sexual misconduct. Those have all been fleshed out a lot more too. So I would encourage people to look at those, particularly as I note down here, sections 83 through 89. Next slide, please. And there are expanded triggers with regards to potential issues of competence, health, or ethical conduct. Where a licensee witnesses another licensee to act in a way that they deem reasonably discriminatory or sexually abusive, they have a requirement to report as well. And I want to be clear too, anytime someone reports, it does not automatically mean that their an investigation is fully triggered and that they are going to get castigated and punished. The role of the college too, I know for many, there can be fear about this, but the role of the college is not to drum people out. Again, we understand that licensees are there to support and uplift the public also. The vast majority of people who we interact with and we know are out there, we know are doing good work. That's why we're all in this work together. And even where, say, there may be, I can't speak obviously for an inquiry or investigation committee, but I do know that regularly the goal is to be restorative, to rehabilitate, to look at how can we fix the situation so that there's no more further risk of harm, that harm is addressed, right? So we're not here to drum people out. In fact, that would be counterintuitive because the fewer services, as we all know, we're stretched thin already. The fewer the services, that does not help the public either, right? We just want to make sure that the public is getting safe, ethical, and competent services. Okay. This is a big piece, patient consent exemption. So this is one thing that is quite different. Under the HPOA, an SLP does not require patient consent to make a regulatory report where a colleague's acts refer to sexual misconduct or sexual abuse. So whereas previously we would have needed that consent from the patient, that is no longer the case. We are obligated to actually report regardless. Okay. Next slide, please. And that's me. Thanks very much.
Okay, thank you all. So this is the time that we will be moving to questions. So you can enter question in the Q&A box. We will also have Anita who will moderate the question we had pre-submitted. We can go back to the other slide. I'll quickly do that mention before we move on. We hosted last week a webinar by Elaine Alecht on cultivating safe spaces. It was really, really well received by all licensees who attended. If you were not able to attend, we have shared the recording with all of you, and we would really encourage you to watch it if you have a chance. It was a really great session. Elaine Alec is an Indigenous person, and she really approached this from her lens, and it was really great to hear her perspective on how licensees can consider self-care belonging in human capacity. And there's another slide before we move on. We have spoken about this at the beginning, but I'll just re-mention it, that we have definitely 3 webinars that are particularly connected to the topic that we spoke about today. We had a webinar on standard on March 18. We hosted a webinar on restricted and certification on March 24th, and also a delegation webinar on January 14. They're all on our website. So Anita, this is now to you. And if we could also make sure that we spotlight my other colleagues, which I may ask to contribute to some of the question answering. Yeah, thank you.
Thanks, everybody. Okay, we'll move over to the questions, and we really appreciate all the feedback and people giving us in the registration form some indication of what you want to hear about today. And perhaps some of that will have been covered, but perhaps not. So let's start with a big one, an overall question. This person asked, why has everything changed, and how can the college apply the same standards to all healthcare professionals when we do very different work?
Great question. Susan, could you speak to that, please? Oh, you're muted, Susan. So I was wondering why I didn't hear you.
Sorry about that.
See you. Yeah.
Sorry. That's okay. And I was just saying I'm thinking about a few different things I want to cover on that front. I think, first of all, the important part is to know that these standards it truly was a harmonization project. So we looked at all of the requirements that all the 7 sets of legacy standards had, and we represented those in the ethics and practice standards that are now in effect. We essentially were much more alike than we were different in the legacy standards already. We were often just saying things with slightly different language, but in general, standards around consent, privacy, communication, they were already very similar. So as some of the practice advisors have pointed out, there are changes, some significant with respect to things like how long we hold records for, because we had lots of feedback from registrants saying, this doesn't make any sense. I'm an OT. Why do I have to hold my records for 16 years? And my colleague who's an SLP has a different retention period. So where there were conflicting sort of requirements that didn't really make sense, we looked, so for that one in particular, we looked to the Limitations Act, and we sought a legal opinion to decide what was the right number to land on, and then we made that harmonized across all of the professions. The second piece to know is that, and AJ mentioned it, when we talk about right touch regulation, it's about getting the regulation at the right level. So what is the statement that really expresses the requirement of the health professional that if it were breached, the college would actually would take action? And so we don't want to drill down to such a prescriptive level that it reduces your ability to exercise professional judgment. So I often think, if you are, let's say you're an audiologist and you're treating, a 16-year-old or an 18-year-old, some of how you assess that client is going to look quite different than how you're going to assess somebody who's 88. And you need to, your regulation, if it itemizes everything that your assessment must require, in some cases, it's going to mean that you're sort of required to do some things for one patient that's not actually indicated or wouldn't be considered best practice. So the notion is to get the standards at the right level, that it captures where we feel there's risk of harm to the public or where the college would take action if that standard statement or requirement was breached, but to not write it so prescriptively that we eliminate your ability to retain your professional judgment about what is the right way to meet that standard with the patient in front of you, which can change from patient to patient, but you can still meet the standard. So I hope that helps. And as AJ said, or Nick might have said at the beginning, really, this is the standards written at a slightly different level is not intended to change practice. So I think that's key to remind people of, that practice remains the same and that the standards reflect that. There are a few changes, as I say, to align where we had discrepancies or where we needed to add some things to meet the requirements of the HPOA. And then beyond that, we are hoping to develop some guidelines or not hoping, we plan to develop guidelines to assist registrants in applying those standards into practice. And some of those will likely be profession specific.
Thank you, Susan. We have a question about audiology. It says, you talked about the fact that newborn hearing screeners do not need to have on-site direct supervision by an audiologist. But what about audiometric technicians, assistants, who work within public health audiology clinics, assisting behavioral testing, etc.?
I'll give a very high level answer, but because this is very profession specific, Nick, you can probably add on after. That will probably make more sense. But what I am understanding of the question doesn't refer to a delegation of a restricted activity, which is the case for the newborn hearing program, because it involves a restricted activity to insert either a finger device or, I'm missing two other terms, into the ear canal. And so when we are speaking about a delegation, which is the concept defined in the Act, although we recognize this is a concept and a term that was used by people before, it refers to a restricted activity. If this is referring to work that is done with other colleagues, that refers more to an assignment, then that would be different. And then, Nick, maybe that's where I'll let you speak more a little bit, because I get a sense that you know exactly what this is about.
Well, I actually don't have much to add. I was gonna kind of just say the exact same thing as you. Yeah, just the differences between like a restricted activity delegation and assignment. I don't think I have much else to add.
Okay, perfect.
Okay, thank you. So we received questions both in advance and live relating to from SLPs relating to public school districts. So I'll read the one that was live. I used to work in 2 public school districts. With respect to records retention, as far as I know, each school district can retain records other than the permanent student record for however long they wish after the student graduates. How do we make sure the school district retains SLP and psychology notes and reports for the time period prescribed by the college?
Yeah, Susan, will you
Yes.
give a first stab at it? And then I know, AJ, you have experience working in that field. You can add anything after.
Yeah, I think, I feel for practitioners in this position, and I'm a physiotherapist, and physios in the school system face the same issues. And, private practitioners often who work in private settings face a similar sort of a parallel issue around sort of advertising that's out of their control. And so I think we want to remind people that fundamentally, as regulated health professionals, we have an obligation to meet our college standards. So where something is happening in your workplace that doesn't allow you to meet your standards, I think the first thing we would always encourage people to do is to point that out and have a conversation. So hopefully you could go to the school administrators to ask what is their policy, how long are they keeping records, and you could explain to them that the college standards now require that you keep your SLP records for 16 years under the standard requirements, and that it's not a good position it doesn't feel good as a health professional to be in a position where you can't meet your standards. And I would hope that most workplaces will appreciate that and would be willing to have that conversation about how can we meet this to ensure that you are also meeting your college standards. The other thing is, I am aware that sometimes there's 2 pieces of legislation that are intersecting or that are at play here. And so it may be that there needs to be some conversation about where our standard requirement sits with whatever acts are governing the school and how long they retain records. And so that might be something that you have to have a conversation with administrators as well to figure out where that requirement sits. But I think AJ may have more clarity on that.
Yeah, thanks, Susan. I think you covered most of that already. And I'd absolutely endorse what you've said here too. With regards to just what to add to that, I think it's important also for people to recognize you're responsible for your own practice and conduct. You're not responsible for other people's practice and conduct necessarily. I mean, to a degree, if you have a supervisory role, but not even in that case for all the minutia, right? You're responsible for being able to, again, under defensibility, if you were questioned about conduct, if there was a complaint, being able to show how you took those steps. What was your role in advocacy? How did you bring that information forward? So, such as Susan has pointed out, there's a role for us as licensees. If we feel or perceive that our employing agency is not meeting those standards or making it difficult for us to bring that forward to them and present those concerns. Right. And I think that there's a way to do it as well that's collaborative, collegial, in a way that highlights, hey, actually, this is me helping out to make sure that we're all compliant and on the same page, rather than, going and wagging a big stick, which is might work too, but it's certainly in the long term, I think, less ideal. One thing to really consider too, and this is beyond the scope of the HPOA, but something we talk about a lot, is there are different designate roles when it comes to client information and the protection, security, maintenance, all of these things when it comes to client records and client information. And while the client, of course, is always going to be the owner of that information, that's why if they have an FOI request, they can, it might be heavily redacted in many places, but even their own name will be there. That's their information that we're handling there. And we are the author. So that comes with a lot of responsibility about timeliness, accuracy, objectivity, all these things. We're not necessarily, in most cases, and I say most, typically the custodians of that information. Right. We might have temporary custodianship, especially for districts where you're still using more paper records. But ultimately, that's going to come down typically to in the case of a school district, the district itself. And so that responsibility falls on them. It's the same reason why if you were to leave that site, who keeps possession of the record, right? Not you. It will be the district. So that's actually their role and their responsibility. And we do have an advocacy role, but it's not incumbent on us to police or change other people's actions, just to do our best due diligence if we were questioned.
Okay.
Good question.
Our next question is on a different topic. It's about duty to report obligations. This person asks, how does one report? There is a place on the website for the public, but I don't see one for professionals. And I think this is for Susan.
Sure, or Joanie, because my understanding is that actually that's a very good question to ask, because my understanding is that the college is actually actively working on this, and that very soon we do hope to have a duty to report form on the college website for just exactly that reason. If in the interim you found yourself in a position where you had a duty to report, the HPOA stipulates that you report to the registrar. Sorry. So, but you could send that to our complaints department email.
We have that already. So yeah, I've just checked. So I was checking our website to ensure before I say that it's there or not there yet. We do have, it's not probably at the place that is the most intuitive, but if you look under for the public, you will have a section that speaks to submitting a regulatory report, a duty to report, and there's a form that's called regulatory report form for licensees. So the form is specifically built up for you as a licensee if you reach the threshold of having a report to do. If you're unsure if you are reaching the threshold, because that often happens, people are not sure, they're in a situation where they feel a bit on the fence, they want to do well, then you can reach out. There's a contact that's actually written on that webpage where you can reach out to the complaint department, and you'll be able to discuss with someone from the college if that's actually meet the threshold for a duty to report or not. So.
That's great. That was like that. Last time I checked it, the form wasn't up yet, so that was good timing, yes. Joanie, to check, and it's there now. Yeah.
Okay, we probably have time to squeeze in a couple more questions. Here's one from a school SLP. Do I need parent guardian consent for a teacher to ask me questions about a student, or to, quote, just have a quick listen to a student?
Sure. Susan, I know you can speak a little bit to consent and then AJ can add, but if you could speak in general to consent, I think that'd be good. And then we can go into that more specific question because I think consent can generally be of interest for everyone here.
Yes. So the first thing I'd want to point out is that the answer to this does not change at all based on your legacy standards transitioned over to the ethics and practice standards. The rules around consent remain the same, and those are really fundamentally. And there's an act, the Healthcare Consent and Facilities Admissions Act in British Columbia, that sets out all the requirements around consent. And I think this is one where you might have to just have a bit of a thought about what the parents know about you being at the school. So I'm anticipating that perhaps at the beginning of the school year, let's say it's a kindy class, something goes out to the parents to say, this year there's going to be a PT, an OT, and an SLP screening children in the classes. And if anything in particular comes up that warrants more specific assessment, we will reach out for your consent at that point. So if you've got something like that, then I think you would likely say to yourself, well, I feel pretty comfortable having these, conversations around supporting, optimizing, the children in general's, speech and hearing experience in the classroom, or having some high level conversations with the teacher. And then I think once you get down to that spot where you're actually doing a more formal assessment of the child and making recommendations and so on, then of course you would likely feel that, again, depending on what kind of consent or what kind of information was shared with parents at the beginning of the school year, that you would probably want to take another step from that. But you might just want to have a thought about, what did we tell parents? What do they know about me turning up at this school? And would they be surprised to know there was an SLP in the classroom having these conversations? AJ, anything to add?
Yeah. So one thing to note too, especially for those of us in schools working with minors, is the Healthcare Consent and Care Facilities Admission Act. That specifically pertains to adults too. And in BC, we don't have an actual age of majority here. So it is a bit murky grounds. I know our legacy college had more guidance on that also, even though those documents, as I say, are retired at this point or rescinded. But I think, Susan, to your point, like, again, I've said this throughout, like, I would really encourage people to consider, where in doubt, start with the code of ethics. That is a really good place to couch things in, right? Just looking at that now, consider patient autonomy, right? And in my opinion, I see that as the first duty, right? In all things, where those things come in conflict, how are we preserving that individual's right to be informed, to consent, to be self-determining? You can't be self-determining really in earnest if you're not informed. So what does that kid and the person who has guardianship hopefully reasonably need according to the level of risk, harm, incumbent to that? So it's pretty innocuous to come in and just have an observation, but you may be holding your any sort of impressions that you have until maybe you have a chance to share them with family, or maybe it is okay. But again, don't do things in a silo. Figure out your school's culture and your district's policies around that, so that reasonably, the right people are informed along the way, so that they know how to manage their own care. Right? Even when we're in schools, we are still healthcare providers.
I also think, listen to your professional gut instinct. And if you're asking that question because you feel like the consent process that you're currently using is not adequate, that's a good sign that it's time to have a conversation with your fellow staff or what have you and re-examine that process. But if you feel comfortable with what's in place, that's an entirely different scenario. But I just say that because I wouldn't want to suggest that if you have concerns about what's happening, that you should ignore those. I always think whenever you have that professional gut instinct, it's usually because you've identified a risk to the public or somewhere where you feel you're not meeting standards. And so I think that's always important to consider.
Can I briefly add to that too, Susan? Just to echo what you're saying there, like, it is important, like I said, with that upside down triangle, ultimately the responsibility as a licensee falls onto you to make that final determination. So that also means, with informed consent, your district may have policies, or your employing agency might have policies, but you still have an obligation reasonably at the end of the day to ensure that you've competently met that, right? So if that doesn't pass that sniff test for you, so to speak, then you need to take those actionable steps to actually meet that. But that threshold may be different from context to context, person to person, but it is still an important thing that is ultimately up to us individually to determine at the end of the day.
Okay, thank you for that. We've come to 1 o'clock, and I think Joanie wants to finish off with a few words.
Yes, thank you. So you've been seeing on that slide, you have the email for practice support. Just want to mention that when we receive queries, it is a general inbox, but then depending on which profession you are, it is getting filtered to the right practice advisor. So please reach out to us with any question. I know there's probably a couple of questions in the chat that we didn't address. We will have a copy of these. Either we will follow up with you, you can follow up with us. And we've also, for other webinar, tried to look at probably kind of creating like a Q&A that we send as a follow-up to these. So we'll look at these and see what's the best way to address the remaining question. And we will try to plan, as I said, additional engagement in the fall, whether it's on the topic of quality assurance or licensure or other topics that are of interest to you. So thanks a lot for engaging with us. We really appreciate these opportunities of being able to answer more questions in this format. And we hope that was also useful to you. So have a good Friday afternoon.